Good afternoon. Welcome to our session on patient-ventilator interactions. I'm assisted up here on the podium with my good friend Jordi Mancebo, and I am Neil McIntyre. Our first speaker is from the Hines VA system in Chicago, Illinois, Saram Parthasarathy. Try it again. Parthasarathy. There we go.
That's right.
Speaking on patient-ventilator interactions, how to evaluate it, and how important is it?
Thank you for the introduction. It's a pleasure to be here in Brussels. And so this is what I was going to talk about, patient-ventilator interactions, how to evaluate it, and why is it important. So Fred Astaire and Ginger Rogers were the famed dancers who were well known for their graceful movements, and fluid movements, and their skill and their synchronization. So this is what we would want between the patient and the ventilator, is adequate and good synchronization. Now, how did these great dancers achieve that? They achieved that by a lot of rehearsal, fast reflexes, and visual cues. We certainly can't make our ventilator and patient rehearse or give each other visual cues, but we can certainly do something about reflexes. So if we break it down, the patient-ventilator interaction, we can actually break it down into what is usually conceptually considered as a two-pump system is actually a three-pump system. You have the inspiratory muscles and the expiratory muscles, two different pumps in the patient, and then you have the piston pump, which is part and parcel of the ventilator. And these are interacting with each other, but the complexity begins when you consider the fact that besides the brainstem, you have the cortex that is controlling breathing here and inducing variations in the breathing pattern, as opposed to just a microprocessor, which is a simple circuit that is performing at the level of a brainstem. And what is more is that the communication between these two systems is still the same old archaic flow and pressure-based system. And this is how it was conceived. Mechanical ventilation was conceived, and this is how we are still continuing to do it as of today. So the complexity gets worse when we consider the fact that we have this going on in various time frames. So shown here are the inspiration and expiration, inspiration being positive. And we have to consider this for a single breath, as well as for multiple breaths. And for a single breath, shown in orange there is the I to E, or inspiration to expiration switch point. And then we have the immediate post-trigger phase, which is a part and parcel of inspiration. Then we have the bulk of inspiration. And then we have the E to I, or expiration to inspiration switch point. And then we have expiration. And of course, all of this occurs over multiple breaths. So we have to not just look at the single tree, but we have to look at the entire forest. And we will, as we go along in this talk, I will try to exemplify on that. So the thing about this is that this is a cycle, and each one of these phases seems to spill over its effects into the subsequent phase. And finally, it comes a full circle. And that's what I wish to expound on over the next 5 slides. So over here, this slide essentially shows us how there can be a prolonged time that can lapse before inspiration can actually trigger the ventilator. Shown top to bottom are the raw diaphragmatic EMG, a processed signal of the same diaphragmatic EMG, and then we process it even further and get a moving average, which looks nice and clean. And then, of course, we have the esophageal pressure, which drops maybe a tad before the start of inspiration, which is defined by that little arrow there. And if we zoom in there, we find that during this phase of inspiration, which is 0 to 360 degrees, as defined from the diaphragmatic EMG, the start of inspiration based on flow is a long way away from 0 degrees. In this particular case, it's about 120 degrees, which is sort of a lag between when the patient inspires and when the ventilator actually kicks in. Now, what is the effect of that? The effect of that is there's an increased amount of patient effort required to trigger the ventilator. Not only does that happen during the trigger phase, as shown in the green bar here, and I'll explain this in a little bit of detail, but it also spills over into the next part of inspiration, or the bulk of inspiration, what we call the post-trigger or the immediate post-trigger phase. So to sort of simplify this, we have flow up here, we have airway pressure, which is the second row, and we have this effort calculation down here. And in this effort calculation, this dashed line up here is actually how the normal chest wall compliance would be reacting. Any deviation of the true measured esophageal pressure from that downwards mean that the patient is sucking down, sucking in, or is putting in some inspiratory effort. If it were higher than that, that means the patient is actually putting in an expiratory effort. So here you can see that there is an increased amount of inspiratory effort before the triggering occurs, the triggering being denoted as the start of inspiratory flow. Plus, there is also continued increase in inspiratory effort after the fact. And during the bulk of inspiration, this could become even more manifest if the amount of assist or support given by the ventilator, meaning the level of pressure assist for pressure support ventilation, or the inspiratory flow in assist control ventilation, if they were mismatched to the patient effort, with increasing amount of effort, you can see that this flow tracing scoops. So this is probably the only flow tracing or flow waveform analysis that I do day to day in the ICU, but even then there are some pitfalls about that. Because when we see this, we either increase the assist or we increase the inspiratory flow. But the truth of the problem is that we can't be at the chain to the bedside monitoring this on an every minute, every day, every hour basis. And that's where I think there is the underlying fallacy of doing waveform analysis and correcting patient-ventilator interaction. So this is a slide which denotes what happens subsequent to the inspiratory phase. Shown here in the inner circle is the patient's phase of inspiration shown in yellow and expiration in red. And this is the ventilator. And you can see that the trigger phase and the inspiration and the expiration of the ventilator is well matched with that of the patient. Whereas if there was a phase lag, as we talked about, if auto PEEP or intrinsic PEEP induces that phase lag, we have this sort of dial effect where it just turns it around. We already talked about how there can be a prolonged inspiratory delay when the ventilator is triggered. We talked about the post-trigger phase. But what happens is that inspiration starts early and ends early. And what that means is that expiration starts early as compared to inspiration. And this period of overlap is what we see in the next slide. Over here, you have flow up on top, airway pressure, and you have the transverse abdominis muscle EMG. And the transverse abdominis muscle EMG was obtained by using ultrasound-guided needles. And you can see that commonly oft talked about is the fact that there's a spike in the airway pressure tracings, which is said to mean that there's expiratory muscle activity that's premature. But unfortunately, we can't be analyzing transverse abdominis muscle EMG in the ICU, nor is the spike in the airway pressure tracing a reliable measure. But what does this really mean? What does this mean to the patient? What it actually means is that there is less time for exhalation. So the impact of occlusion on dynamic hyperinflation, which was done by McDeonis in Canada, shows that we could artificially induce this sort of phase delay in when mechanical exhalation starts as compared to neural exhalation, which starts here. So this is the delay that was induced by inducing an occlusion to the exhalation valve. And as a result, as you can see, there's less time available for all of the air that went in during the prior inspiration to come out. So there's less air that's coming out. So what does that mean? If there's more air coming out in the previous breath, less air coming out this breath, that means the rest of the air is stacked in. In other words, you have dynamic hyperinflation. So this is a slide which I just put it up here just to show the fact that when Eunice and colleagues induced these occlusions, the occlusions, or the duration of time of the occlusion is shown in the x-axis, and the dynamic hyperinflation is shown on the y-axis. The main idea of this graph is to show that all of these values are positive. It goes from 0 onwards and 0 onwards, and there are only about 3 patients down here who are staying or 4 patients down there who are staying down stuck at the x-axis. In other words, all of them developed dynamic hyperinflation. So what? So what does dynamic hyperinflation do? Well, such dynamic hyperinflation can actually be caused by further amount of delayed exhalation that occurred in the prior breath. This slide shows, it's a little bit complex, so just stay with me here, shows that this periods of overlap is measured from up there from 0 down to minus 90 degrees, which is essentially called the phase angle. So the further you are away from 0 means that there is more amount of overlap in that expiratory period. And more overlap means more dynamic hyperinflation because it means more occlusion. And you can see right away that for pressure support of 0, 10, and 20, there's increasing amounts of delay or mismatch. And between triggered breaths and non-triggered breaths shown in cyan and the non-triggered in yellow, you can see that the non-triggered breaths, the breaths preceding the non-triggered breaths, were more likely to have a greater amount of mismatch. So for each level of pressure support, the amount of mismatch in the prior cycle was greater for the non-triggering attempts. So what does this mean? Well, so far we motivated patient-ventilator interaction, or the study of patient-ventilator interaction, by the fact that there is this increased effort, both during inspiration as well as during expiration, that can actually increase the amount of oxygen consumption of these muscles and maybe injure these muscles. But then Franco Laghi's work put a spanner in that motivational line that I could use in my papers by suggesting that when patients are breathing spontaneously, they are not even on the ventilator. After a period of spontaneous breathing, all I want you to do is focus on this particular bar here. At the end of a 40-minute trial, shown on this axis, these patients are returned back to the ventilator by the physician because of increased effort that is evident, and they still have about 13 minutes left before task failure occurs. So when a twitch study was done on these patients to look for muscle fatigue, there was no muscle fatigue. So if patients could breathe spontaneously at high levels of tension time index or respiratory load to capacity ratio and still not suffer from muscle fatigue, how can one postulate that patient-ventilator interaction could actually injure muscles? Well, one could postulate that because of this fact. Plyometric contraction. What plyometric contraction is these are actually ineffective breaths or non-triggering breaths that we talked about just a while ago. And these are occurring here, shown on the flow tracing as an artifact during what appears to be exhalation, but these are actually inspiratory efforts that fail to drop the airway pressure down far enough for it to trigger the ventilator. What you'll notice is that during this period of time, the lung volume keeps dropping. The efforts are weak, and they're not able to surmount the dynamic hyperinflation at each of these points until the very end, where it's able to surmount it because the lung volume is low. What it means is that the inspiratory efforts are occurring at a time when the lung volume is dropping, or at a time when the diaphragm is actually lengthening. Such a contraction, or plyometric contraction, can be damaging. And this is shown in rat studies by Petrov and colleagues back in 1993, in which they did the study for a different reason, but these were actually the control rats, which were contracting normally versus during plyometric contraction. And this is actually an orange stain used to show disruptions in the sarcolemmal membrane, suggesting that plyometric contraction can lead to swelling and injury of the sarcolemma and the diaphragmatic muscle. So not only is muscle injury a factor in patient-ventilator interaction, or the impact of patient-ventilator interaction, but here these are studies that are being performed at our laboratory, where we're actually doing polysomnograms in these ICU patients, critically ill patients. And this is actually a polysomnogram, and during that period of time, we are actually capturing video at the same time. And here, top to bottom, are all the tracings in a polysomnogram, starting from EEGs to electrooculograms to electromyograms, electrocardiograms, and flow and such. What I want to do is, if the audio would work, is listen to the ventilator noise, you see it cycling. Whereas here, you hear there's no cycling occurring as we would hear normally with the exhalation valve going off. But what follows immediately after that is this. And you can see that the patient takes in a breath and prevents the apnea alarm from going off any further and moves a little bit and tosses around, and the patient starts, the ventilator starts cycling again. So what was happening there, and I wanted to show that because I used to see things like that and did not make much of it until we started doing polysomnograms, and that was actually in a short period of an apnea. And sometimes it may not even be an apnea, it might be hypopnea. And what it results is in sleep disruption. So each of these apneas that occurs here ends up with an arousal or an awakening. So what can happen is that depending upon the mode of ventilator, assist control versus pressure support, we can find that sleep can be more disrupted during pressure support during the time which these apneas can occur. So what does sleep fragmentation really mean? This is actually not from critical care literature, it's from patients with sleep apnea. Bottom to top, you have respiration with evidence of apnea, some of them with desaturations, and some of them with surges in blood pressure that follow these apneas. And this is muscle sympathetic nervous activity. In other words, the sympathetic nervous system is revved up in response to these arousals. The same thing can happen, same tracing as before. There are blood pressure that's measured down here between assist control and pressure support. Surges in blood pressure can occur at the end. And these surges in sympathetic nervous system activity can be deleterious. I'm going to skip a couple of slides. So what I want to actually get down to is the fact that it's really difficult to monitor patient-ventilator interaction and be at the bedside of the patient, make the changes, look for the flow tracings, even though these are talked about all the time. I don't know about you folks, but I don't stay chained to the bed and keep changing all these settings and looking at these waveforms. What I think should happen with patient-ventilator interaction is not more than how to evaluate it. I think we need to have a complex and sophisticated machine to do the evaluation and do the changes. But there are problems. This is a study done by Shar, which used PDI tracings, and of course the work of Cinderby, which uses neural diaphragmatic EMG to essentially run the ventilator. They correct the non-triggering breaths without you having to make any changes to flow or PEEP or any such thing. So what we did was we improved the reflexes by these EMGs, but what we probably need to do is give the machine a cortex. And what we need to do is we need to have some well-defined goals, and so for the complex network that runs the ventilator or automated mechanical ventilation, we need to have supporting evidence that poor patient-ventilator interaction is bad, and we need to counter the effects of unknowns, such as a runaway phenomenon or propagation of breathing instability. And with that, I will end the talk.
Thank you. We have a couple of minutes for questions, if anybody has them. While we're waiting, you and the group in Chicago have done some fascinating work here. Apart from the cycling issues, which are clearly important, and you described them very nicely, during the inspiratory phase, the goal, it doesn't seem to me, is to totally it's not to totally unload the respiratory muscles, but rather perhaps to put some kind of a bias on the respiratory muscles to assist them. I guess what I'm asking is, what sort of target should we be looking for? How much assistance should we be giving? We don't want to take them to zero, at least I don't think we do. But as you point out, we certainly don't want to be loading them with sort of high pressure, low volume kind of work. What kind of a goal might we be shooting for?
Short answer is I don't know. I mean, I don't think we know that.
I don't either. I was hoping you were going to help me.
Because the long answer is that that's why the last slide ended up by saying that we need to find out what these goals are. Because if we have a complex neural network that's running the ventilator automation, we need to be able to tell it where to go.
Yeah, this just seems to be the simple part is telling it when to start and stop. A much more complicated issue to me is figuring what to do during that inspiratory phase.
So the level of assist.
Right.
You don't want to assist all the way because then the muscle will fatigue and, will atrophy. At the same time, you don't want to do it under.